So one of the very first things you're going to want to get cemented down into your head when you're thinking about approaching a trauma patient is your initial approach. And the initial approach includes stabilizing the patient. Obviously, this is most important because if you don't stabilize the patient and they need to be stabilized, they die. And the initial approach is part of making your diagnosis or ruling out anything that can be of a very imminent harm to the patient. So the initial approach and stabilization is the first thing you're going to want to know about when you're thinking about trauma surgery. So the first step in management of any patient, but especially the trauma patient, is to ensure that they have an adequate airway. So we think of our ABCs when we think of all patients, but especially trauma patients. So airway and breathing. And this is because if you aren't breathing properly, if you don't get oxygenation, this will kill you much faster than if you have some kind of circulatory problem. So airway and breathing tend to take precedence over circulation, even though they're all very, very, very important, the utmost importance. Airway and breathing you're going to check for first. So starting IV fluids and getting the patient onto an EKG and getting their oxygen started and getting all your labs and imaging and Foley catheter to check urinary output. These are all very good things to do in a trauma patient, and you need to do most of these things, but they're all superseded by ensuring that the patient has got an adequate airway that they can breathe through. Now, something that you're going to see with trauma and assessing and evaluating and treating a trauma patient is that it works kind of the opposite way to all of the other patients that you see in a non-trauma setting. So as in a non-trauma setting, you kind of go, you get your history, you get your figure out the symptoms, you do your physical exam, you do your diagnostic test, and then your treatment. With the trauma patient, you're more so doing your immediate treatment and then kind of your diagnosis based on symptoms, and then after the patient has gotten all that, then you get your history. So it's kind of done in an opposite, reverse manner. And that's something to keep in mind when we're thinking about how we are approaching the trauma patient. So the first question is, does the patient need to be intubated? And this is part of securing an airway. So as a rule, trauma patients who are unconscious need to be intubated. As another rule, if a patient has an expanding mass, which is usually going to be a hematoma in the setting of a neck injury, the patient's going to need to be intubated because you're not going to be able to get rid of that expanding mass until you get them in to the OR. And invariably, you're going to need to intubate these patients before you treat them, so you may as well intubate them right away before you get any kind of problem with the airway, because that expanding mass in the neck is going to ultimately compress the airway and compromise the patient. Another thing, if the patient has desaturation or they have declining mental status, you're absolutely going to intubate the patient. And then if there's the subcutaneous crepitation of the neck or upper chest, and this is going to be part of your chest exam, which falls under the B of your ABCs, you're going to want to intubate the patient. So the easier question might be, when doesn't the patient need to be intubated? And for the most part, if the patient is conscious, talking normally, they have normal breath sounds, and they're saturating fine, then they probably don't need to be intubated. And for the most part, you will be able to, it'll be pretty apparent what patients need to be intubated and which patients really don't need to be intubated. But if you're teeter-tottering on whether or not you need to intubate or not intubate, you should probably intubate. The complications of intubation when you don't need to are much less severe than the complications of not intubating when you need to, which would be death. So if any question, intubate. The intubation methods and techniques, primarily we use the orotracheal intubation route. And so this is, although requires experienced training and is a little bit more technically difficult than the nasotracheal route, for the most part, this is not very difficult to do. And usually in the US, we teach medical students how to do this in their 3rd and 4th year, and by residency, you should get relatively comfortable with this. In the event that the patient has a cervical spinal injury or they're on a C-spine collar or board, then you can use bronchoscopy to assist placement. And that can be a little bit more difficult because for them, they need to keep their neck perfectly still and stabilized. Nasotracheal intubation can also be done. You're seeing this less and less common but this is slightly easier to place. You may see if a patient was intubated in the field, the EMT may have used this route because it's just easier to do. Either of these are fine, they're equivalent, but there's one time when you will never do a nasotracheal intubation, and that is if you suspect injury to the cribriform plate, or if there is injury to the cribriform plate. Cricothyroidotomy or percutaneous tracheostomy, a lot of times we see this done in patients who need to be intubated long-term, but this can also be done right away, I suppose, if you need to, and one of those cases where you will need to is if there are facial fractures present or suspected. So it makes sense that if you have facial fracture problems with the skull, you're not going to be able to stick something into the head, which would be through the mouth or through the nose, because you don't want to hit any vessel or any bone that's in a problematic spot. So this is going to be your answer if you have facial fractures present or suspected: cricothyroidotomy or percutaneous tracheostomy. What will never be your answer in the emergent setting, in like the ER or in the trauma bay, is a surgical tracheostomy. This is always only done in an OR where you have sterile technique and all of that stuff. Surgical tracheostomy is never done emergently. This is called the Selleck maneuver. So we do this for unconscious patients. We need to intubate because we're doing this emergently, they're at risk for aspiration. So in most of the time when we do intubation in the hospital, when we have to put the patient in for surgery, they're NPO for a certain amount of time, so we know that they don't have anything in their stomach. Well, we don't have this luxury when it's an emergent intubation. So if the patient is unconscious, which will be the most of the patients, I would say, that you need to intubate, or even decreased level of consciousness, you're going to do this, what's called the Selleck maneuver, and all you're doing is applying backwards pressure on the cricothyroid cartilage, and this helps reduce the risk of aspirating stomach contents. So only for unconscious patients. The conscious patients would be able to vomit the stuff up without aspirating. This is the Malampatti classification. This is going to help you determine how difficult the patient is going to be to intubate. So most people are in class 1 or 2, but a small minority of people are in the 3 and 4, and these patients are much more difficult to intubate. So this is kind of more of a general surgery thought, but when you're putting a patient in for surgery, you always want to make sure that you have their Malampatti classification known so that you know, do I need maybe a new anesthesiologist, and not necessary to have a very experienced anesthesiologist, or do I need to have an anesthesiologist who's very, very, very good at placing airways? Because 1 is pretty easy to do. 4 is the kind that you'll want to have a good board-certified, experienced anesthesiologist on board, so that it's not you can get this airway put in right away. So the B part of our ABCs is breathing, and so this is going to apply to everybody. You'll want to make sure that you're assessing the airflow and the breath sounds through the chest. There's some very, very important things that you'll want to rule out that can be in any trauma patient that if it's there, you'll want to make sure it's diagnosed ASAP because they can be life-threatening. And the first thing that would come to mind would be a tension pneumothorax. So what this is a tympanitic hemithorax. You'll have no breath sounds. You're getting injury to the airway, which is causing air to go into the pleural space but not out. And so you're getting an increased pressure in the pleural space, and this can ultimately cause shock. So we're very concerned about this. It's very easy to rule this out right away. Just listen to both sides of the chest. If you hear breath sounds on both sides of the chest, you're pretty much good to go. Another thing you can see is a hemothorax, and what you'll note here is a hemithorax that's dull to percussion because you've got fluid in it, blood, and you will hear your breath sounds, but they'll be distant. They will be asymmetrical. A paradoxical chest wall movement you should be able to see just grossly by looking at the patient. This indicates a flail chest, and this is usually caused from multiple rib injuries in the same area. And the paradoxical chest wall movement, all that means is that when the patient's breathing in this area, it looks like the patient's breathing out, and vice versa. So that's a flail chest, and that's caused from multiple rib injuries. And then palpable crepitation of the chest wall, you'll want to make sure that you rule this out in all trauma patients. This is indicative of a tracheal bronchial injury, and this will require immediate intubation. So a good way to assess how the patient is breathing apart from your chest evaluation is just to assess their airway and make sure that they've got good saturation. Good saturation generally means that breathing and airway are good. So C is our circulation, and this is usually assessed by monitoring the blood pressure and the heart rate. For the most part, if there's a compromised circulation, blood pressure is going to drop and the heart rate is going to climb. You can assess your pulse with the carotid artery, radial artery, really anywhere you feel comfortable. Carotid artery is usually the easiest, but some people prefer the radial artery. I put the carotid artery here because you're going to want to make sure that you look at the patient's neck. So why do we want to look at the patient's neck? If a patient is in shock, if their blood pressure is abnormally low, we want to know what kind of shock is it. Is it hypovolemic shock? Is it shock due to a pericardial tamponade? Or is it shock due to a tension pneumothorax? These are the three most common shocks you see in trauma. So if it is a hypovolemic shock, it's because the patient is losing blood. It can be externally or internally. If it's externally, it should be obvious. If it's internally, this is where that fast exam comes into play. And so if a patient is, most of the time you do a fast exam on any trauma patient, but if a patient is in shock, you'll want to make sure you do a fast exam on them to check for internal bleeding. We're mostly looking for bleeding in the thorax, in the peritoneum, the retroperitoneum, and behind the bladder, in the pelvic area. Next thing we want to ask is the blood being pumped properly? Because this can give rise to two of the other kinds of shock. So the pericardial tamponade is where we get blood surrounding the heart. And if that happens, the heart is not going to be able to pump properly because you have pressure on the heart and it can't expand and pump. And what's going to happen here is you're going to get backflow, just like you would get in congestive heart failure, because what do we have in congestive heart failure? A heart that's not pumping properly. What do you get in pericardial tamponade? A heart that's not pumping properly. So you'll have distended neck veins. The jugular veins will be distended. And that tells you it's not hypovolemic shock. It's a shock from either a pericardial tamponade or a tension pneumothorax. An intention pneumothorax, which is due to a chest wall injury, which causes air to come into the pleural space but not leave, you get an increased pressure on one side of your chest, and that's going to compress the heart, just similar to pericardial tamponade, but instead here we have air pressing on the heart rather than fluid. And so this, again, because the heart's not going to be able to pump properly, you're going to have a shock and a low blood pressure, and most importantly, it's going to reflect back up through the venous circulation, and so you'll have that distended jugular vein. So that will be in both of these, both in pericardial tamponade and in tension pneumothorax. The way you're going to be able to tell these two apart, most obviously, is going to be the fact that in pericardial tamponade, the patient can breathe fine. In tension pneumothorax, there is dyspnea, shortness of breath. And so that's going to help you differentiate the two of these. Other things that you can see, pericardial tamponade, you may hear distant heart sounds. In tension pneumothorax, you may hear that tympanitic chest, absent breath sounds on one side of the chest. So there's other things, but shortness of breath is the most obvious one. All right. So if the patient is pulseless and not breathing, in addition to, and this is just CPR, if they're in the hospital setting, you're going to want to make sure that you intubate them, of course, right away. But if they're in the field or you don't have intubation available right away, you're getting the crash cart sent down, the first thing to do is CPR. CPR can be done inside or outside of a medical setting. So CPR is just 30 pumps, and that's pumps on the chest, right below the nipple line. And usually you're using the heel of one of your hands, and you're going at about 100 beats per minute. And then next thing you'll want to do is tilt the head back and lift the chin, and that's going to help you get a good airway so that you can deliver the breath into their lungs. And what you're going to look for also is make sure that the chest is expanding. And this is mouth to mouth. You want to make sure that you're getting a good seal on the patient's mouth, because if you're not, then the air is just going to escape without going into their airways. So this is sort of your basic life support for the patient. For the most part, though, the patients in the hospital, you'll be intubating. I talked more about sort of the CPR stuff, the advanced cardiac life support in the cardiology section, so you can check there for more information about this. Now, if you have a pediatric patient, you pretty much do the same thing. Only difference is instead of going 100 beats per minute, you're going to go maybe 120 beats per minute or more, especially if it's a neonate. And then, of course, you're going to use less pressure and less breath force. So usually the pitfalls to delivering CPR are insufficient pumping pressure. So I've seen a lot of medical students who are a little bit shy about this, and that makes sense because we're all shy when we're doing something for the first time. You want to make sure in an adult that you're compressing 1.5 to 2 inches, so that's about 3 to 4 centimeters down into their chest. You may cause rib fractures, especially if it's a little old lady with osteoporosis, but the fact is a few rib cracks is worth it if it means keeping the patient alive. In pediatric patients, the rule of thumb is 1/3 to 2/3 the depth of the chest. Another thing that you can see in the CPR deliverer who is maybe a little nervous or they may not allow for recoil. So you've got to make sure that you allow the chest to come all the way back, because what are we doing? We're making sure that the heart can refill with blood, and if you're not allowing for recoil, you're just pumping an empty heart. So got to allow for recoil, and then not looking at the chest to see if it's rising. You've got to make sure that you're getting air into their airways, and so if you're not looking at their chest to see if it's rising, you're not really doing anything necessarily. All right, so that's CPR. In a nutshell. And the, I should say ACLS, Advanced Cardiac Life Support. This requires an EKG and an established IV line, and this is addressed comprehensively in the cardiology section. Okay, so this pretty much covers your A, B's, and C's. So your airway, breathing, and circulation. And there's a couple other things that you're going to want to make sure that you are assessing as well after you've assessed these three things and made sure that your patient is stable. So the first would be disability. And when we're thinking about disability, for the most part, we're thinking neurological status. So I've seen two different perspectives. One says that the Glasgow Coma Scale is really complicated and you should use that later. The other is saying that the Glasgow Coma Scale is very accurate and is very very good for assessing for outcomes and whether the patient needs to be treated for certain problems. And I would say that for the most part, you can use this AVPU scale for assessing their neurologic status. However, if the patient has a head injury, you should use the Glasgow Coma Scale. So that's my opinion. But you should be aware of both of these systems for the USMLE. So the AVPU scale is basically as easy as it sounds. Is the patient awake? Do they respond to verbal command? Do they respond to pain? Or are they unresponsive? One of those four. Simple as that. The Glasgow Coma Scale is a little bit more complicated, a lot more complicated. So what we're looking for with the Glasgow Coma Scale is their motor response, their verbal response, and their eye response. And these are assessed on a 1 through 6, a 1 through 5, and a 1 through 4 scale, respectively. And so that gives you a rating of 3 to 15. And this is just, in general, a better scale to use if you're dealing with a patient with head injury, because it will tell you if the patient has a mild head injury, a moderate head injury, or a so-called severe head injury. So those are usually the patients where you'll want to do a more complex assessment of their neurologic status. So the motor response, And for all of these, you're just taking the highest one that they do. So if they obey verbal command, it's a 6. If they localize the pain to stimulus, then it's a 5. Flex and withdraw, it's a 4, and then down from there. With verbal response, if they are oriented and they converse with you properly, then it's a 5. If they're disoriented and they converse, it's a 4. If they're using inappropriate words, and by that I don't mean swear words, I mean they're just babbling inappropriate words that don't make any sense, that's a 3. If they're just making sounds like a baby, then that's 2. And if there's no response, that's 1. And then the I response, you can see here as well. So the Glasgow-Coma scale is a much more specific way to assess patients' neurologic status, but the ABPU system, for the most part, will get you by in most trauma patients. And then E stands for exposure. So you want to expose the patient, cut off their clothes with your trauma shears to assess for injuries, bleeding, and so forth. But because the patient is undressed, you got to make sure that they're adequately warm. And usually what we do to keep them warm is the notoriously warm trauma bay. So if you work in a level 1 trauma center, you'll know that when you go into that room, it's like 85 degrees in there. And the reason for that is because the patients are usually going to be naked. And so you want to make sure that they're warm. Warmed IV fluids is excellent when possible. And then blankets can be used also when not examining or when you're finished examining. And then after resuscitation, what you're going to do is a trauma series, and this is imaging. So a chest x-ray, which you should get both a lateral and AP view, as you should always get when you're looking at the chest. A cervical spine x-ray, at least 2 views, pelvic x-ray, and a CT of the head. Especially, well, always, if there's altered neurostatus or reported head injury. A fast exam can be part of your initial ABCs, but it can also be part of after resuscitation, just depending on the state of the patient. And so fast exam is called, is just short for focused abdominal sonography for trauma. And that what you're looking for here is the pericardium. So you can look to see if there's any blood accumulating around the heart. You're looking at the spleen, you're looking at the liver and the kidney, and the bladder. Labs that you should always have ordered in any trauma patient are CBC, CMP, a beta HCG. You want to know if the woman is pregnant because that may alter our management. Urine tox screen, especially looking for alcohol and drugs, and coagulation studies in case we need to give the patient blood. Foley catheter, generally you're going to insert these because if we're giving them fluids, we want to make sure that they're producing urine, but we may need to we may need to insert it for other reasons. The only time you're not going to insert a Foley catheter immediately is if the patient has a pelvic fracture, because we are concerned then about the possibility of urethral damage. And then tetanus, you should know their tetanus status. A lot of times patients who get into car accidents, motorcycle accidents, get stabbed or something, they're at risk for tetanus, and so we want to make sure that they have been immunized within the last 10 years, and then if they haven't, we can use a prophylaxis. And then finally, the history. So usually you start with the history, but here we're ending with the history. Ample is the way you remember the history. So either you ask the patient, you ask the EMT, whoever's with the patient, allergies or alcohol use, medications, past medical and surgical history, and if they're pregnant. But otherwise, we can get the beta HCG. When was their last meal? That's important for intubating. And then events surrounding injury, which is going to be important as far as what you do next after the resuscitation period is over.